Okay, you guys, this is the last lecture. I don't really remember what week it is. 12 maybe, not sure. Anyway, congratulations. You made it to the last lecture. We're going to be talking about emergency nursing in chapter 72, and then I don't remember what the other chapters are, but it's burns and I don't know. Don't have it with me. Okay. I'm going to go back and stick in some objectives at some point. So just roll with it. All right. So what is emergency nursing? Okay. So initially, traditionally, emergency nursing has always been referred to urgent and, critical needs of patients. Okay. We've always thought of it as the place that you go whenever you had an emergent problem. But now, more than ever, with all our healthcare changes that are taking place, there are a lot of people, well, not now because of affordable care, but up until just recently, there were so many people that did not have insurance that it was increasingly used for non-emergent problems. In light of Affordable Care Act, there really should not be as many people presenting to the emergency department with non-urgent needs. However, there are still people who come to the emergency room because they can't afford their deductible or copay or whatever the case may be. Long story short, the bottom line is that you're going to see everything from a toothache to life-threatening injuries in the ER. So emergency room, emergency management has broadened the definition, the understanding of what emergency nursing is, incorporates whatever the patient or family considers to be an emergency. That's what emergency nursing is. So an emergency is whatever the patient says it is. Okay? Our nursing interventions are often, implemented in a much more independent manner. Okay, there is a lot of autonomy in the ER. You work collaboratively with the physician, other nurses, nurse practitioners. So our interventions are accomplished independently, interdependently, in consultation with a physician or a nurse practitioner or PA. All right, priority emergency measures that we need to be aware of for all patients. Really doesn't matter what the situation is. Safety is always first. It's always the priority. So we've got to do a lot of anticipation to make sure that our environment is safe and the environment is secure. So that means watching families, watching the patients, looking for issues of violence, watching how people respond to stress, how they cope with stuff, and just being aware, being clued in to situations that could potentially be a problem. You always want to be aware of psychological issues, psychosocial issues between patient and family, and just watching the dynamics of what's happening, okay? Interventions are always patient and family focused. We don't just treat the patient, we have to treat the family that came with them as well. So our actions are aimed at relieving anxiety and promoting security for both the patient and family. So the family is allowed to stay if at all possible. You explain things, you talk to the patient and the family. You have to make sure that you assess things like HIPAA and who is legal next of kin, who can you talk to. You can't just go in and start giving information to whoever's in the room, but as long as you know that they are an approved person, the patient has said, okay, yeah, you can talk to them, then you can give information, and you should give information to those people. And then, of course, any intervention that's necessary, depending on what's going on at that stage or at that time, then you would tailor your interventions specifically to the situation. Some of the common issues in emergency room care, of course, consent and privacy. All right, we just because they roll through the door into the ER and think they have an emergency, or we think it's an emergent situation, we still have to get informed consent. Okay? Now, there are some situations, if the patient is unconscious and there are no family members and it's a life-threatening situation, the doctor can deem it a true emergency, and we can proceed with life-saving measures or procedures without informed consent. But, if there is any way at all to get consent, we have to do it. Privacy issues, HIPAA violations, you have to be very careful about who you talk to for legality purposes, okay? And we've already talked a lot about that this semester. There are some inherent exposure risks, Hep B, Hep C, HIV, even greater risks today, airborne problems, TB, things like that. So you have to be very diligent to use your personal protective equipment as necessary. Violence is common in the emergency room because it's high stress, it's a high emotion place. So again, you have to kind of be aware of your surroundings and what's going on with family and the dynamics that you see playing out there. We are responsible for providing holistic care in the ER. We are not just treating that single problem that they have come in for. So you really have to work on being patient-focused with your interventions as well as family-focused. You want to keep the patient calm. You want to portray calmness. You want to portray confidence. Okay? If you can portray these things, it gives your patient a greater sense of security. Keep the family informed. Make sure they're aware of what's happening. Deal with anxiety levels. Therapeutic communication does wonders to reduce anxiety. So talk to the patient, talk to the family, talk to them specifically about their anxiety. Help them, with coping mechanisms. Talk to them about their feelings. Validate their feelings. That will help them tremendously, and it will help to reduce the stress level. Okay? You also have to really work with them in terms of anger and grief. Those stages of loss, guilt, anger, grief, acceptance. You've got to help the family in some cases work through these stages, okay? So you have to really establish a rapport with them early on and then be there for them, okay? So that goes into that caring, holistic care that we need to provide as emergency room nurses, okay? Discharge planning, a lot of these patients go home. They don't just get admitted all the time, so we've got to really be focused on helping them go home to be healthy. What kind of services do they need? Are there any referrals or contacts that we need to make before they are sent home? Do we need to set up referrals to community agencies, support services, referring agencies, anything like that? We need to make sure that they have all that information before they leave. All right, triage is one of the foundations of the emergency room, okay? It is kind of the intake or the beginning place. It's how most emergency rooms are set up these days. The patients come in and they are seen by the triage nurse. And this is a way to sort patients based on their severity or their acuity, okay? And the patients that are sicker or have more immediate needs are going to be seen first. So the triage nurse is the person that does all the initial assessment, and it's a very brief assessment, okay? Collects data and then determines the severity of the illness or the injuries and kind of classifies it according to the protocols or policies that are in place, okay? The triage that you see done in the emergency room is different than triage that's done in a disaster situation, okay? So when we move into disaster, talking about disaster mass casualty, that's a little bit different, okay? But the protocols that are used for the just regular emergency room triage are developed usually collaboratively by nurses and doctors, okay? And it's based on generally 3 categories: emergent, urgent, and non-urgent. So the emergent category, patients that are placed in the emergent category have life-threatening illness or injury, and they need to be seen immediately. The urgent category means that they have serious illness or injury, but it's not life-threatening. They need to be seen within 1 hour of admit, but they don't have to be seen immediately. The non-urgent are conditions, illnesses, or injuries that can be addressed within 24 hours. They are not deemed to be a detriment to the patient in any way, to their life or health in any way. So when you hear people say that they came to the emergency room and they had to sit for 6 hours or they had to sit for 10 hours, it is because they were triaged and their illness or injury was deemed non-urgent. Now, the non-urgent issues are the ones that we try so hard to get them to go to the quick care or the velocity care or whatever these other places are, or get them to go to their doctor's office, okay? That's where we try to get our non-urgent cases to go. All right, so when we're talking about assessment of our emergent and urgent patients, our goal is to do a very rapid assessment, get the patient stabilized, provide any kind of essential treatments that they might need, prompt treatment that is appropriate to the level of care that they need. Okay, so part of that initial assessment, that rapid assessment, is our primary survey, the ABCDE. Okay, we talked about this a little bit at the beginning of the semester, but in the emergency room setting, and it's all the same basic stuff. We've talked about this before. Do they have a patent airway? Are they able to breathe? Do they have adequate ventilation and perfusion? As far as circulation, can they maintain circulation on their own? Do they require any support to maintain circulation? Drugs, fluids, anything like that. Do we have to give them anything? Are they needing anything to enhance cardiac output? Do they have any disability? And this is where, we're looking for neurologic disability. They're going to use the Glasgow Coma Scale, a GCS scale, especially paramedics and EMTs, out-of-hospital providers focus on a GCS scale to determine neurologic disability. And then we're also looking for other areas of disability, if it might be limb, not just life, but limb related. And then exposure has to do with an area of injury or a trauma. We need to have good exposure of that body part, Okay, so if it's you know, a broken arm or a broken leg or a burn or, you know, anything on an extremity, we would definitely want to remove the clothes from that area. If the patient is unresponsive, then the first thing we want to do is get the clothes off of them and get to their chest so that we can see what their chest looks like, rise and fall, get them on an EKG, that kind of thing. Our secondary survey is a little bit more in depth. This is completed once the primary survey is done and the patient is stable. Okay, so we don't shift into secondary survey until all of the immediate needs are taken care of. It includes the health history, all of the past medical, medications, social history, all that kind of stuff. Full health history, a full head-to-toe assessment, any diagnostic or lab testing that needs to be done that hasn't already been done as part of that. In the primary survey, there's really no lab work that's done here in primary. So our secondary survey is where we really start doing diagnostic testing, x-rays, and lab work. Okay, it's also the time where we get them hooked up to the monitor. We're going to put them on EKG if they're not already on it. They might be getting a catheter. They might be getting invasive lines or an NG tube. You know, this is our moving into care, providing care. Also at this time, if the patient is not critical, life-threatening, then this would be the time when we would put on any kind of splints or braces, you know, stabilization of fractures, reducing fractures if they need to have like a closed reduction or something like that. It is also the time when we would provide wound care, cleaning and debriding of the wound, suturing, putting on a dressing, giving pain medication, you know, any other interventions that would be necessary, calling in consults, notifying family members, anything like that is all part of that secondary survey. All right, some priorities for emergency measures. Of course, this is kind of your ABCs. All right, so airway obstructions, you know, if there were to be an airway obstruction, then of course you would do your abdominal thrust, or if it's just obstruction from, you know, like the jaw or the tongue, you can do, you know, the head tilt, chin lift, or if we have a C-spine injury, we do C-spine stabilization, we would do a jaw thrust instead of, you know, lifting the chin instead of tilting the head, okay, for cervical spine stabilization. Always want to position a patient to maintain an open airway, use oral or nasal airways if necessary, intubation or a laryngeal mask airway if necessary, you know, if the patient can't maintain their own airway. If they're having trouble breathing, then we can always bag to, you know, to help them or support them. If they don't have adequate spontaneous respirations, and of course, you know, if intubation necessary, then we would put them on a ventilator. Priority as far as circulation would be frank hemorrhage. You know, if they're bleeding, you need manual pressure. Place a tourniquet if it's over an extremity. There is questionable use of Trendelenburg positioning now. They're saying to do a modified Trendelenburg, not to lay them, you know, head down, but to keep the head flat and elevate the legs. So, but, you know, hemorrhage, we definitely want to get that under control. Signs of hypovolemic shock. Definitely want to, you know, replace fluid, give vasopressors to elevate blood pressure, you know, look for those causative signs and symptoms. You know, if it is hemorrhage, of course, then control the bleeding and then blood replacement, albumin maybe. Another priority of emergency care are wounds, injuries. You want to know how they happened, when they happened, all of the details um, about that injury or that how did that wound occur. You definitely want to do a good assessment of the wound, and then good cleaning and debridement if necessary, and then wound closure, either sutures or staples, skin glue. You know, there's a lot of different methods out there now, but that's going to be part of that um, process. And then, of course, our last priority emergency is going to be trauma or patients with multiple trauma. Okay, so we've already talked a lot about this. Partial or complete obstructions, again, abdominal thrust, positioning of the head or lifting the jaw, nasal or oral airways. Make sure you review how to put in an oral airway, the proper way to do it. We've talked about intubation already. King tube or laryngeal mask airway are just different types of breathing apparatuses. They are similar to ET tubes, but they don't go all the way down into the trachea. The King tube is pretty much only used on ambulances, okay, with paramedics and EMTs. A laryngeal mask airway you might see in the hospital, and we can talk about this in class if y'all will remind me. It's better if I can kind of show you instead of just talk about it, because an LMA just sits right above the trachea at the larynx, and it just kind of basically blocks off the upper aspect, keeps the patient from aspirating. So we can talk a little bit more about that in class. And the same thing with crikes. You really probably won't see too much, regardless of what you see on TV and on Grey's Anatomy. Crikes are really not common. They are definitely not the preferred method. So if y'all will remind me, we can talk about that in class. And then, of course, if you have an intubated patient, then you would want to ventilate them either with positive pressure via manual bagging or on a ventilator, okay? Hemorrhage, again, our goal is to control bleeding, maintain adequate circulating blood volume, prevent the patient from going into shock. So you would definitely look for your signs and symptoms of shock: diaphoresis, cool, clammy skin, changes in blood pressure and heart rate, decrease urine output, all of that stuff that we just went over not too long ago. Fluid replacement, in a case of hemorrhage, you immediately want 2 large bore IV sites. I'm talking no less than an 18 gauge. And an 18 is really not big enough. You really need more like a 16 or a 14 gauge. But you want 2 of them for blood administration or albumin or Hespan, whatever, whatever you can get your hands on. And then control of bleeding. External, applying a tourniquet above the site of bleeding. Manual pressure is always best, first line, because you can always do manual pressure. It doesn't take anything but your hands. There's no equipment to go get. Internal control is going to be, surgical related, having to stabilize that patient and getting them to the OR, okay? And then, of course, like I said, there's questionable research about Trendelenburg these days. Keeping them supine at the very least, and then assessing for signs of shock, okay? Pressure points for hemorrhage control. These are just a little pictogram about, where you can put your hands if a patient's bleeding. This is just kind of a review kind of thing. All right, for wounds, our goal is to restore physical tissue integrity and functioning and to minimize scarring, and of course to minimize or prevent infection. Okay, so those are our big goals with related to wounds. So cleaning is going to be with saline often to wash it out, and sometimes we're going to mix some antibiotic with saline, so we have an antibacterial agent. Sometimes we're using chlorhexidine to scrub that area. Might also be debriding some tissue that doesn't look so good. So, wound cleaning is part of the emergency room. And then our closure, our wound closure, we have a primary and a delayed. Okay, so primary closure is done right then. Sutures, staples, skin glue, anything where it can the wound can actually be physically closed completely. Delayed wound closure or a delayed primary closure is those cases where the wound is dirty. It's a very high potential to get infected, and so we're actually going to leave it open and allow it to drain if it needs to drain, or we might be leaving it open to allow it to granulate from the inside out. Okay, so that's what delayed primary closure refers to. As far as wounds go in the ER assessment, your assessment needs to be aimed at when and how it occurred. I've talked about that already. But you need a very accurate and a very descriptive documentation of the patient's description of the event along with a detailed description of the wound itself. Size, depth, color, description of the edges. Take pictures according to the facility policy and procedure. Okay, using use aseptic technique when you're cleaning the wound, when you're assessing the wound, when you are trying to determine size and depth, and if there's any foreign bodies in there. So you're using aseptic technique during all of that, and then documenting, taking pictures, and retaining any evidence that you might be removing from that wound. Things like bullets or any objects that might potentially be there. Trauma refers to intentional or unintentional injury beyond the level which the body can maintain homeostasis. Okay, so trauma doesn't necessarily have to be an intentional injury. It can be unintentional, but it just refers to the fact that the body can't maintain homeostasis anymore. Okay, so in cases of trauma, intentional or unintentional, either one, we do have a responsibility to collect forensic evidence, which is what I was just talking about anything that you might find in the wound. So a very thorough assessment, thorough documentation, description of all wounds, photos, making sure that we hang on to any clothes that are removed or other personal articles, jewelry or anything like that that might be removed from the patient upon arrival. Especially valuables have to be documented. They have to be secured so that nothing happens to them. You need to document who you gave them to. All specimens or swabs or samples that are taken from the patient or from wounds or anything like that, especially if they're taken for evidence, you have to, you have responsibility to keep up with that, because a lot of times you're working hand in hand with law enforcement in the emergency room. Okay, so collection of that evidence is very important. We also have a responsibility to protect the patient from injury or, to prevent additional injuries. So a lot of patient education about, if this is an unintentional injury, then we've got to do a lot of education with this person so that it doesn't happen again. Okay? In cases of multiple trauma, we deal with those, in the emergency room. It's a team approach. Okay? Everybody kind of pitches in, and we're trying to figure out the extent of those injuries and determine what needs to be dealt with first. What are our priorities? You always assume cervical spine injury until it's ruled out. Okay? So you would always treat that person as if they have a cervical spine injury until, leave them in a C-collar until we can get their spine cleared. And then any injury that interferes with physiologic processes or vital functioning, they always have the highest priority. Okay, so, if we've got blood pressure, circulation, airway issues, then that has to be dealt with first. Those patients have to be treated first, and they have to be stabilized first. Okay, patients with intra-abdominal injuries. These can be from, motor vehicle accidents. Blunt trauma is typically, they're usually either blunt trauma or penetrating trauma. So blunt trauma would be an MVA, a fight, abuse situations, beatings, falls, stuff like that. And then penetrating is going to be gunshot wounds, stab wounds, anything that actually penetrates the body cavity, so to speak. Okay? Blunt force trauma or blunt force injuries are harder, of course, to diagnose because often initially you don't see any injury. With penetrating injuries, obviously, there's a problem there. Okay? So the blunt traumas, well, either one of them can cause massive blood loss, life-threatening blood loss. But those blunt traumas that we don't see initially, those patients can actually bleed into their abdomen or into their chest cavity pretty quickly. So we have to be very diligent and quick with our assessment, okay? So you really have to get as much information as you can quickly. Get a history and try to find out what happened, and then do a very rapid abdominal assessment. You're looking for distension, tenderness, changes in bowel sounds. Is the patient guarding? Any rigid muscles? Is the belly growing or getting distended, changing over time? And then assessing other body systems, chest, kidneys, back. You're looking for things like retroperitoneal bruising, looking for any injuries or anything that accompanies abdominal injuries, okay? Also need to be very diligent about your assessing for referred pain, because that can be indicative of organ damage, spleen, liver, or intraperitoneal problems. Quick CT scan, lab studies, UA, serial H&H's, CBCs looking for increased white cells, white count, platelet function, liver function tests, just trying to get an idea of if there's bleeding and where it's coming from, okay? With GU or urinary related injuries, with males especially, and this is really important to know that, if it's urinary related in a male especially, the male needs to have a digital rectal exam before you put a catheter in, because if they have urethral damage or urethral involvement, a lot of times if you put a Foley in them, you're going to actually further damage the urethra. So a digital rectal anytime there's suspected urinary problems or urinary trauma, then hopefully somebody's going to do a digital rectal first before you put in a Foley. Other issues with abdominal injuries, of course, we've got to maintain ABCs in cervical spine immobilization, assessment, thorough and constant ongoing assessment, documentation of wounds. You want to be very specific about is there any viscera that are protruding? In your documentation, that needs to be clear and descriptive. And then, of course, if they present to you with their intestines on the outside of their body, anything protruding that should not be external to the body cavity, then you immediately need to cover it with a sterile, saline-soaked gauze dressing. Okay, we want to keep it moist. They immediately are made NPO. You don't want to stimulate the intestines when the intestines are located outside of the body. That patient is headed for surgery because we have to fix it, so they have to be NPO for that, and you don't want to stimulate the gut. So no oral intake, NPO, and then NG tube, most likely drop an NG tube to decompress the stomach. They're going to need a tetanus shot, and of course if their guts are external to the body cavity, then they're going to need prophylactic antibiotics. And then preparation for surgery. All right, crush injuries. It's the next category of injury we're going to talk about. Crush injuries can involve a body part or the body as a whole. Okay, so it can be a person, as in a whole body, or a body part that is caught between two objects or two opposing forces. Okay, and it just crushes, that body or body part. So when we're talking about crush injuries, you have to observe the patient very closely. Your assessment is aimed at anticipation and prevention of hypovolemic shock, paralysis, skin damage, erythema, blistering, other damage to the body part, and renal dysfunction. Okay, so hypovolemic shock might result once the pressure, if we're talking about full body pressure. Okay, if it's a whole body involvement, then once they relieve the pressure from the crush forces, then the patient may actually go into hypovolemic shock from massive blood loss. Okay, internal bleeding. Paralysis, erythema, blistering, that kind of thing refers more to a body part than the whole body. But swelling, redness, loss of motor and sensory function, loss of circulation, have to be very diligent about assessing for compartment syndrome. Also need to be aware of renal function from prolonged hypotension or from muscle damage. Anytime there is a massive amount of muscle damage, it can lead to myoglobinuria, which is a release of myoglobin from muscle breakdown. Okay, creatinine kinase, we've talked about that before, and so that massive dumping of creatinine kinase leads to myoglobinuria, which can lead to rhabdomyolysis, and that condition leads to development of acute renal failure. So renal dysfunction can occur from hypotension, and it can also occur from rhabdomyolysis. Okay, so you have to be very diligent to assess about both of those. Management, of course, ABCs, renal function, extremity care, splinting, neurovascular checks, fractures, splinting fractures, um, review fractures on your own, go back and read up on types of fractures, and just the basic neurovascular considerations with those. Controlling of bleeding, surgical debridement, repair, so getting them ready to go to the OR if necessary, which would be NPO and informed consent, and then assessment for compartment syndrome. Make sure that you go back and review that as well. All right, environmental emergency. We're going to run through some of these pretty quick. Heat stroke. It's just a failure of heat regulating mechanisms, and it's the result of prolonged exposure to environmental temperatures greater than 102 degrees. I find this amusing every semester when I do it because we live in Louisiana, and it is not unusual for us to have temperatures greater than 102. And in most cases, we don't develop heat stroke, but it is very common down here. It is very likely when we are outside working in temperatures of that degree that heat stroke will develop, especially because we live down here and there is so much humidity. It's even more of a risk, okay? The very young, the very old, and the debilitated are at higher risk. And also, anybody that is on, has CNS alterations, or they are on CNS altering medications, if they have altered mood or mental status, or those people who are not accustomed to the heat and the humidity. So your cousin who's visiting from North Dakota, who decided it'd be a great idea to come to Louisiana at the end of July, is at risk for heat stroke because they are not used to the heat and the humidity, okay? So you just have to be aware. Anybody that's on, CNS meds or pain meds or, some of the psych drugs, they can really be at risk. All right, so the first step in the process is heat exhaustion. Okay, that's what actually develops first. In heat exhaustion, your patient can have a temp. They might be normal up to as high as 104. Okay, they're going to feel weak. They're going to have hypotension. They're going to be vasodilated, so they're going to have hypotension and be tachycardic, increased thirst, these are warning signs. Okay, nausea, vomiting. That's a sign that something's not okay. They're too hot. The exertional type of heat exhaustion is just a healthy person that gets too hot because of activity, sports, being outside, working in the yard, whatever, okay? And then the hyperthermia is the next stage where we actually have inadequate heat loss. Those normal mechanisms that the body normally would implement to take care of elevated temperature don't work anymore. So the patient stops sweating, they lose their ability to sweat, they become disoriented, they have hot, dry skin, tachycardic, hypotension, CNS dysfunction, and then the temperatures can get in excess of 104, and that can lead to brain death. Okay, so definitely want to be aware of your assessment findings when the patient presents, because that's really going to kind of tell you what stage they're in. Are they in heat exhaustion, or are they moving toward true hyperthermia? Our management, of course, is to reduce the temp as quickly as possible and maintain all ABCs. So we have to assess the core temp. We want a true core temp. We want either rectal, bladder, or esophagus. Okay, those are the really considered the most accurate internal core temps. We're really shooting for a temp of 102. You don't have to cool them slowly. You know, like we warm up a patient. You don't really have to cool them off slowly. You just want to get them cool. Okay? And our target is to get them down around 102. Mortality is directly related to the length of time that the patient's temperature is up. Okay, so we've got to get them cooled off as quickly as possible. Cooling blankets, cool sheets, cool towels, sponge bath, ice to our, groin, neck, axilla, ice lavage, NG tube, colon lavage. We're not trying to really necessarily prevent shivering at this point. We're just trying to get them cooled off. So monitoring vital signs, level of consciousness, urine output. We don't want them to become hypothermic. We don't want to get them below normal. We just want to get them down. All right, the next emergency that we're going to talk about is hypothermia. That's defined as a core temp that's less than 35 degrees Celsius, which is 95 degrees Fahrenheit. Typically, it's from prolonged exposure to low temperatures, or it can be from a loss of ability to maintain your core body temp. So there are different reasons. Most of the time it's exposure, but you can see hypothermia in cases of the elderly who can't maintain their own body temp. So again, it's a core temp less than 95 degrees Fahrenheit. Elderly, of course, are at greater risk, and infants, people with comorbid conditions that might affect the ability to regulate body temp. Of course, homeless, lower socioeconomic status, alcoholics, especially homeless alcoholics. Alcohol, of course, causes systemic vasodilation, which is going to lead to heat loss. So alcoholics in general are a little bit greater risk, but especially if they are homeless in inclement weather. Okay. Hospitalized trauma patients can be at risk from use of large amounts of IV fluids if those fluids are at room temperature or colder. If they're blood products, maybe, that have just come from the refrigerator, and we're having to give several units of blood, then those patients are definitely at risk of hypothermia. Anytime you have large fluid volume resuscitation, you should always be using a fluid warmer to maintain the patient's body temperature. It really doesn't take but a couple of units of blood or a couple of liters of fluid to really start dropping that core temp. So, in cases of trauma or patients that you're having to resuscitate emergently, you've got to pay attention to that. Hypothermia, very common in the wintertime, of course, especially in areas where there are really severe temperatures, or in situations where people aren't used to, like here, we don't typically have really cold weather, and so that will catch a lot of people unprepared. Often seen with frostbite. But our treatments for hypothermia, we've got to get them back to a normal body temp, a normal core temp, before we deal with frostbite or any other situation like that, because They can live without a hand or a foot or a leg, something like that, but we've got to get them normothermic. There's all kinds of physiologic changes that take place. When the temperature drops that low, they're going to be confused, delirious, drowsy. The colder they are, the more depressed the CNS system is. Dysrhythmias are common. There's going to be acid-base imbalance. They're going to be acidotic just from hypoxia, because the colder they are, the slower their body processes become. So they don't breathe deeply, so they become acidotic. They will have the shivering mechanism until their core temp reaches 90 degrees. And then once they get below 90 degrees, they lose the ability to shiver. So that self-regulating, self-warming function disappears. So it's very, very important that we monitor very carefully and on a continuous basis whenever we have a patient who is hypothermic. Management of patients with hypothermia, of course, ABCs. Breathing, obviously, airway, breathing, circulation. Got to get any wet clothing off of them. Anything that is contributing to the reduction in body temperature, we've got to get it off of them. Continuous EKG monitoring, close observation of blood pressure, respiratory, O2 sats. We've got to start rewarming measures, active core rewarming. We use for moderate to severe hypothermia, which would be anywhere between 82 and 90 degrees Fahrenheit. And yes, I have seen people that cold. I think the coldest I've ever seen a patient come in alive was about 86, 87. So yes, they can survive even when they're that cold. Active core rewarming can be done via cardiopulmonary bypass, which would be the same thing that we would do for heart surgery, just put them on a bypass machine. Warm fluids, warm humidified oxygen, peritoneal lavage with warm fluid. Those are all considered active rewarming. There's a great propensity for VFib between 88 and 90 degrees because as the heart begins to warm, the ventricles get very irritable, and there's a lot of not just fluid shifting, but there's a lot of electrolyte shifting going on. So there is a very real risk of ventricular dysrhythmia as you rewarm the patient. So it's essential that they're on EKG and that you monitor closely. Our passive rewarming is more external, not an internal warming or a core rewarming as with our active processes, but external rewarming for mild hypothermia. That's for patients that come in between 90 and 95 degrees Fahrenheit. Warm blankets, heaters, forced warm air like bear huggers, warmed blankets, putting a blanket around their head, kind of tucking them with warm blankets. So there's a lot of, even though it's external, we're just putting warm blankets on them, or we're using a bear hug or a forced warm air blanket, there's still a lot of patient safety, not just in monitoring the patient, but when you put those forced warm air blankets on a patient, you've got to monitor them and make sure you use them correctly or the patient will get burned. Okay? You also have to really note that once you put the blankets on them initially, if it's just regular cotton warm blankets, it feels good at first, and then it loses some of the heat, and the patient will actually start to shiver again. So you kind of have to keep an eye on that. Also, you've got to remember that when the patient begins to warm up, and as they vasodilate just a little, that cold blood, as it begins to circulate, coming back from the extremities, has a lot of lactic acid in it. And again, there's the risk for dysrhythmia, and then of course electrolyte disturbances as the fluid shifts. Also, cold blood, or that, not normothermic blood that's returning to the core of the body, can cause what's called afterdrop phenomenon, and that's where the patient's temperature will drop again, after it has come up and been okay for a period of time. Sometimes, during that rewarming process, as the blood circulates and returns to the core, you get what's called afterdrop. So they'll warm up, they'll get closer to normothermia, and you think you're going in the right direction, and then after a little while you'll notice that their core temp is back down again. That's known as afterdrop phenomenon. You also have to monitor them very closely, because as the patient warms up, vasodilation occurs, and as they vasodilate, they will become hypotensive. So you have to remember, being cold causes vasoconstriction, causes the patient to clamp down and shunt everything to the core or to the vital organs. So as you warm the patient, they'll vasodilate, and then there is a real risk for hypotension associated with that. So our nursing management, of course, ABCs. Airway is essential, especially if the agent is inhaled or swallowed. Many poisons actually will burn or scar the airway. So you have to really pay attention. You have to know what was ingested, try to find out as quickly as possible, and you have to keep in mind that not only will the agent burn going in, but if it's something that was ingested and it causes the patient to vomit, then it will also burn as it comes back out. So ingested poisons, if it's inhaled, that's one thing. I mean, it's going to burn as it's inhaled, but if it's something that the patient drank, if it's something they swallowed, it's going to burn going down, it's going to burn coming back up. That's why we don't induce vomiting anymore on purpose. Used to, we gave everybody Ipecac and would induce vomiting thinking we could get it out of the system. But we know now that some agents, it's more harmful to induce vomiting because it burns the airway or the throat, the esophagus, causes more damage as it comes out. Definitely want to be looking at vital signs and level of consciousness, EKG, and urine output. A lot of ingested poisons will immediately cause the patient to go into renal failure or will affect urine output. Some ingested poisons will discolor the urine, and then in some cases it causes release or breakdown of muscle, which will lead to a buildup of creatinine and put the patient in rhabdomyolysis. So lab work, looking at electrolytes, renal function. If it's something that, if we can identify what the agent is, maybe it's something that can be tested. If it's an alcohol-based substance, then we can do an alcohol level. So there's different lab tests that might be used. Definitely need to know what was taken, when it was taken, how much of the substance was ingested. With kids, we always ask the parents about cleaning solutions or anything that might have been, within reach of the child. Pill bottles, you always, out of hospital first responders know to look for empty bottles. They always look for whatever's closest to the child. But you want to know how much was in that bottle to start with. So that's something that you would ask the parents. If it's medication that maybe a kid got into, how full was that bottle when they started? Looking for signs and symptoms of poisoning or tissue damage, pain, irritation, redness of the throat and the mouth. Are they having trouble swallowing? Do they complain of a sore throat or burning in their throat or esophagus? Are they vomiting? Do you see sloughing of tissue? Things like that. You also want to know their health history, age and weight. which are very important. Age and weight are essential to treatment because you have to know many of the antidotes are based on size, BMI, so height and weight are essential. Also, with health history, you want to know about allergies and then comorbid conditions. Do they have heart problems? Do they have lung problems already? You need to know what kind of baseline you're dealing with. And then it's a requirement that you notify poison control. That's the best thing to do anyway because they have ready access to information about all kinds of poisons and antidotes that are recommended. So anybody that comes into the ER with a poisoning or a suspected poisoning, we're going to notify poison control. Other issues or management techniques related to removing the toxin. We're either going to try to remove it or decrease its absorption. So if it's something that we know it's safe, it's not a corrosive thing or that's going to burn, then we can use emetics. But if it's something that's corrosive or that will burn, such as an acid or an alkaline, then they typically will just try to flush it with water, either have the patient drink water if they can, or milk to help to dilute that agent. If the patient is not able to drink, then most of the time they're going to drop an NG tube and they'll do gastric lavage. That's safer to do with an NG tube because it's not, we can get it out through the tube. But that would be very important to know whether or not your patient is able to swallow well, and then what the agent is. If you're not sure what the agent is, then having them, of course, using emetics is out of the question. Other agents, activated charcoal is very common. That's a binder that we will use with patients who overdose because it's just activated charcoal. It is, charcoal is just absorbs pretty much anything it comes in contact with. So especially benzodiazepine overdoses, narcotic overdoses. Of course, we can reverse those, but still, a lot of times, aspirin, Tylenol, acetaminophen, we can give activated charcoal to help to use as a binder. They also will sometimes use ipecac to induce vomiting, but again, you would never do that if it was a corrosive poison. Always give the drug-specific antidote or antagonist as quickly as we can. Mucomyst is our common one for Tylenol. Y'all know that. Narcan for narcotics, and Romazicon, or the generic is flumazenil for benzodiazepine overdose. Other treatments include diuresis to flush out the kidneys, and then dialysis. If it's a large volume of something and we're worried about not just renal failure but multi-system failure, then they can dialyze the patient and clean out the system quickly. Definitely important to teach the family and the patient signs and symptoms to look for once we send them home. Not all patients are kept. If it's an intentional overdose, like a suicide attempt, then of course those patients are kept for a psych consult. But if it's an accidental overdose, and we know it's accidental, it's ruled accidental, then they will treat the patient and stabilize them. And if they're okay in the ER, then they might possibly go home. So it would be a case of educating the parents about what to assess for, or family members, just things to assess for once they get home. All right, the next disorder I'm going to talk about is carbon monoxide poisoning. Carbon monoxide has a very great affinity for binding to hemoglobin, about 200 times greater affinity for hemoglobin than oxygen. So whenever carbon monoxide is inhaled, it will bind to hemoglobin molecules much quicker than oxygen, and it'll take the place of oxygen. Carbon monoxide is an off product or an exhaust or a waste product from like gas generators. So anytime there is poor ventilation or a tight enclosed space with gas heaters, that's where you get the carbon monoxide exhaust. When carbon monoxide binds to the hemoglobin molecule, it creates carboxyhemoglobin, which basically just takes up place on the hemoglobin molecule and blocks the oxygen so no oxygen gets transported. Manifestations of carbon monoxide poisoning are mostly CNS related, mental alterations. If the patient is awake, they're going to seem drunk. They might complain of headache, dizziness, palpitations, confusion for sure. They're going to be confused. And then there is a rapid decline of mental status as the exposure is prolonged. Okay? Skin color is not reliable at all because carbon monoxide gives them a very pretty red color, okay? A cherry color, like a cherry red. So they don't look hypoxic. They are hypoxic because there's no oxygen being transported, but they don't get that characteristic cyanotic color or pale color, okay? And you also can't depend on your pulse ox because the pulse oximetry is, all pulse oximetry measures is how much the hemoglobin is saturated. Now typically, in the body under normal conditions, hemoglobin is saturated with oxygen. But with CO poisoning, the hemoglobin molecule is saturated, it's just not saturated with oxygen. So the pulse ox monitor will actually read 100% because it is fully saturated, it's just not saturated with oxygen. So our physical assessment findings can be, not accurate in this case. So that cherry red color, and then our 100% saturation, and your patient is just as hypoxic as they can be. Our treatment is aimed at getting fresh air in, getting that CO flushed out. So the patients, need to be educated about safety, especially in the wintertime. They need to know to have adequate ventilation. And then in cases where we suspect carbon monoxide poisoning, you got to open the windows, open the doors, get to fresh air immediately, and then as the mental status declines, or if they're unresponsive, then of course CPR. Administer 100% oxygen initially, and then the real treatment for CO poisoning is to get them to hyperbarics. That's where they are taken down into what we call a dive. The goal of treatment is to reverse the hypoxia and to get that carbon monoxide off of the hemoglobin molecule. And that's why hyperbarics is so good at that, because the hyperbaric chamber is a pressure chamber, and they actually will lower the atmospheres of pressure just like when you're diving. And as you lower the atmospheres, it forces the carbon monoxide off of the hemoglobin molecule. And hyperbarics is, not only are they lowering that atmospheric pressure, but it's a pure 100% oxygen infused environment. So as they force the CO2 off of the hemoglobin molecule, then the oxygen can immediately bind. So hyperbarics is the gold standard treatment for carbon monoxide poisoning, and it's very effective. As they take them down in atmospheres, that oxygen can infuse and can bind, and the patient, typically if we get to them quick enough, they'll turn around and they don't have bad outcome. Got to have continuous monitoring, of course, of mental status, oxygenation. So think about, how would you check oxygen levels if our pulse ox is not accurate? How are you checking the oxygen level? And then, of course, monitoring signs of perfusion other than color, and then looking for signs of any kind of mental damage or brain damage. A lot of times in situations like this, in the emergency room, you have to rule out, was it on purpose? Was it a attempted suicide? There are people who will crank their car in an enclosed garage, and that leads to buildup of the CO gas. So, sometimes that's a suicide attempt. And then in other situations, like in large buildings or something like that, it's accidental. It's a leak or, just under ventilation. So in that case, you would contact the health department. So you've got to deal with that along with monitoring the patient. So, just a lot going on there. And then, of course, dealing with family and keeping people updated and, that kind of thing without, if it's like a building or an apartment complex or something like that, of course, then you don't want to create mass chaos and send out erroneous information. So it's kind of a balance of information. Okay, the next problem we're going to talk about is poisoning. Of course, that's any substance that's ingested, inhaled, applied to the skin, can be absorbed through the skin, or just anything, any agent that's exposed, the body can be exposed to in any way, even in small amounts, that causes an injury to the body because of the chemical action of that substance. Okay. Our goals is to remove the agent, to get it off the person or away from the person as quickly as possible before it gets fully absorbed, or to limit the exposure. And then, of course, support the patient, protect their vital organs from any kind of damage or side effect, administer antidotes if there are any, and then implement any other kind of treatments that can help to get rid of the poison as